Welcome to the Deep Dive, your shortcut to being well-informed. Imagine your brain, this incredible orchestrator, keeping you balanced, coordinating every single move you make, often without you even thinking about it, right? At the heart of this silent symphony is the cerebellum. But, what happens when this maestro of movement faces a challenge? Today, our mission is a deep dive into cerebellar lesions, assessment and diagnosis. We're going to explore what happens when this really crucial part of your brain and, its extensive network of connections to the rest of your nervous system is affected. Think of it as like a medical mystery where every symptom is a clue.
That's exactly right. By the end of this deep dive, you'll have a much clearer picture of the diverse ways cerebellar issues can manifest themselves and how those subtle clues are systematically identified and what a fascinating process it is to unravel these complex conditions. It truly highlights the intricate design of our nervous system. It's quite amazing, actually.
Yeah. And we'll be exploring a range of conditions, from those that strike acutely, appearing almost overnight, to others that develop more slowly, subacutely, or chronically over weeks, months, or even years. Because, as you'll hear, the timeline of symptoms is often the very first key piece of the diagnostic puzzle. Okay, let's unpack this truly fascinating area of neurology.
Let's do it.
So let's start with the cerebellum itself. It's often called the little brain, right?
Yeah.
Because it looks like a miniature version tucked beneath the larger cerebrum. But don't let its size fool you. At its core, it's the major control center for coordinating your voluntary movements and maintaining your balance. Whether you're walking, reaching for a cup of coffee, or even speaking, the cerebellum is quietly ensuring every action is smooth and precise. It's pretty incredible.
It really is, and it's far from isolated. The cerebellum has extensive, almost dizzying connections to virtually every other major part of your brain and spinal cord. It's like the central switchboard for all your motor commands.
The switchboard, yeah.
And because of these vast connections, issues in the cerebellum can have really wide-ranging effects throughout the body. This is why we subdivide the conditions we'll discuss into acute, subacute, and chronic lesions based on how quickly symptoms develop. That distinction is crucial because it immediately helps narrow down the list of potential culprits you see.
Right, it gives you a starting point.
Yeah.
Okay, now let's put on our detective hats. Imagine someone comes into the clinic, let's call her Sarah, with concerns that suggest a problem with her cerebellum. Before we dive into the specific symptoms, the very first step in any kind of emergency medical situation is what's called an ABCDE assessment. Can you talk about that?
Absolutely. It's standard practice. This is to quickly determine if Sarah is stable or if she needs immediate life-saving intervention.
Okay.
So if a patient like Sarah is unstable, meaning her airway, breathing, or circulation are compromised, the first order of business is immediate stabilization. This can be quite intensive, potentially involving measures like intubation to secure her airway, maybe mechanical ventilation to support breathing, establishing IV access for fluids, and continuous monitoring of vital signs, heart rate, blood pressure, oxygen levels. It's about securing life support first, because, we can't do any detective work if the patient isn't stable.
Right. First things first. But for our deep dive today, let's assume Sarah is stable. That's when the focused history and a thorough physical examination come into play. So if your cerebellum, like Sarah's, was experiencing a lesion, what would you, the patient, actually report? What would you notice?
Well, you might notice a significant loss of coordination. We call this ataxia.
Ataxia?
Yeah. This could mean difficulty walking, maybe keeping your balance, or even just sitting up straight. Picking up objects might become clumsy, or you might just feel generally unsteady on your feet.
Okay, what else?
Another common complaint is dizziness, often described as a really disorienting room-spinning sensation, vertigo. And that can come with nausea and vomiting, too.
That sounds awful.
It can be quite debilitating. You might also report difficulty focusing your vision, perhaps seeing things as blurry or maybe they seem to jump around. Then there are changes in how you speak, leading to slurred speech. Or even problems with swallowing.
Okay, so difficulty coordinating movement, dizziness, vision issues, speech, swallowing. Lots of potential clues there.
Exactly. These are all crucial pieces of the puzzle that Sarah would tell her doctor.
Okay, so here's where the clinical detective work gets, really interesting, I think. What do doctors actually look for on an exam to piece together these clues? To confirm if it's indeed a cerebellar issue and maybe even where in the cerebellum the problem lies?
Right. This is where we try to pin down the specifics. We look for the various types of ataxia, that general term for the loss of coordination of voluntary movement. But the type of ataxia is a huge clue.
Different types.
Yes. First, there's limb ataxia. This is most prominent when a lesion affects the cerebellar hemispheres. Those are the larger outer parts of the cerebellum responsible for coordinating your arm and leg movements. On examination, we look for two key signs. One is dysmetria.
Dysmetria.
Yeah, it's the inability to judge distance properly. So if we ask you to touch your nose and then our finger, you might past point, meaning you'll reach past the target.
Like your internal GPS for movement is off?
Exactly. It's like the calibration is just wrong. The other sign is dystiadochokinesia.
That's a mouthful.
It is. It means difficulty with rapid alternating movements. So imagine trying to quickly turn your palms up and down like you're screwing in a light bulb really fast. If this movement is choppy and irregular, that's dystiadochokinesia, and it's a significant indicator.
So problems with limb movements often point to the hemispheres.
Generally, yes. Then we have truncal ataxia, which affects the core of your body, your trunk. This is most prominent with lesions in the cerebellar vermis. The vermis is that central, sort of worm-like part of the cerebellum, crucial for maintaining your core stability and upright posture.
Vermis, right?
So here, Sarah might exhibit severe swaying of her trunk when trying to sit or stand straight, even if her limbs seem okay. You might also observe titubation.
Titubation?
Yes, it's an anterior-posterior rhythmic tremor of the head or upper trunk, like a gentle rocking back and forth when trying to hold still. It tells us the core stability system is compromised.
Interesting. Okay, limbs, trunk, what else?
Finally, there's gait ataxia. This is about how you walk. It's characterized by a wide-based, unsteady gait. The rhythm is irregular, the stride length is inconsistent. It looks like you're walking on a boat deck in rough seas.
Wide-based gait.
Exactly. And this becomes particularly obvious during what we call tandem testing. That's where we ask a patient to walk heel to toe like on a tightrope.
Ah, the sobriety test walk.
Sort of, yeah. A patient with gait ataxia would struggle immensely with this. That inability to do the heel to toe walk is a very specific sign of cerebellar involvement affecting balance and coordination for walking.
So if I'm understanding this correctly, the location of the unsteadiness, whether it's mainly in the limbs, the core, or the overall gait, gives us a direct hint about which part of the cerebellum might be affected.
That's a key part of the localization, yes. It's like the brain giving us a more precise address for the problem.
That's fascinating. Beyond these different types of ataxia, what else gives us clues on the exams?
We also look very carefully for abnormal eye movements. These can suggest lesions of the flocculonodular lobe of the cerebellum, which is another part crucial for controlling eye movements and integrating them with balance.
Okay, eye movements. Like what?
A key finding is nystagmus. That's rhythmic, rapid eye movements, usually with a fast phase in one direction and a slow phase drifting back. Certain types, like vertical nystagmus, eyes moving up and down, or direction-changing nystagmus, where the fast phase changes direction depending on where the person is looking, are particularly concerning. They often indicate a central nervous system lesion, potentially in the cerebellum or its connections. We also assess for impaired smooth pursuit. That's the inability to smoothly follow a moving object with your eyes. Imagine watching a bird fly across the sky. Your eyes should move smoothly. If they make jerky catches instead, that's impaired pursuit.
Right.
And impaired saccades. Saccades are the rapid shifts of vision between stationary objects, like when you're reading. If you have trouble quickly and accurately shifting your gaze, that's impaired saccades. Both smooth pursuit and saccades require really precise cerebellar calibration.
So much control needed just for looking around.
Absolutely. Other important findings include abnormal speech. We mentioned slurred speech or dysarthria. Sometimes it's called scanning speech.
Scanning speech.
Yeah, it isn't a problem with language itself, but with the motor control of speech. It sounds slow, maybe broken into syllables with varying intonations, almost like someone is carefully, deliberately enunciating each sound individually, but it comes out uneven. And finally, you might observe tremors. A common one is an intentional tremor, which actually gets worse as you get closer to your target, like your hand shakes more and more as you reach for a glass.
Worse when you try to be precise.
Exactly. Or you might see a postural tremor, which happens when you're just holding your arms still in a certain position against gravity.
Okay, so we've gathered all these clues from the history and the exam, the type of ataxia, the eye movement, speech, tremors. But here's where the puzzle truly deepens, right? You mentioned the timeline. How quickly did these symptoms appear? That seems like a huge fork in the road.
It absolutely is. The timeline itself is a powerful diagnostic tool. It leads us down very different paths depending on whether the onset was sudden or gradual. Let's start by looking at acute onset symptoms, those that come on suddenly, often over minutes to hours.
Okay, sudden onset.
With acute onset, the first distinction we make is whether the symptoms are unilateral, affecting one side of the body, or bilateral, affecting both sides. If the symptoms are unilateral and acute, we immediately have to consider a cerebellar stroke as the most likely underlying cause.
Stroke in the cerebellum.
Yes. And the immediate next step is urgent brain imaging, usually with a CT scan or an MRI, to confirm it and see the extent. These strokes are often named based on the artery that's blocked and the cerebellar regions they supply. For instance, a stroke in the superior cerebellar artery, SCA, typically affects the upper part of the cerebellum and maybe the superior cerebellar peduncle, which connects it to the midbrain.
Okay.
An anterior inferior cerebellar artery, AICA stroke, impacts the front and bottom parts of the cerebellum and the middle cerebellar peduncle, connecting to the pons. And a posterior inferior cerebellar artery, PICA stroke, involves the back and bottom sections of the cerebellum and the inferior cerebellar peduncle, linking to the medulla. Each one can present slightly differently.
And you mentioned something particularly interesting about the PICA connection. This is where it gets really fascinating, a real clinical pearl, right?
Yes, exactly. The PICA connection is a classic example of neuroanatomy in action. The PICA doesn't just supply the cerebellum, it also supplies the lateral part of the medulla, which is a critical part of the brainstem right below the pons.
Okay, the lateral medulla.
Right. So patients with a PICA stroke often present with a constellation of symptoms known as Wallenberg syndrome or lateral medullary syndrome. This means, in addition to cerebellar ataxia, they might have dysphagia, difficulty swallowing, and hoarseness, because the nerves controlling those functions run through the lateral medulla.
Wow.
They might also experience decreased pain and temperature sensation. This is key, on the same side of their face, but on the opposite side of their body. It's a very distinct crossed pattern. And sometimes you even see an ipsilateral Horner syndrome, that's a drooping eyelid, constricted pupil, and decreased sweating all on the same side of the face as the stroke.
That's incredible.
Yeah.
A single vascular event orchestrating such a diverse symphony of symptoms. It really shows how tightly packed and interconnected that part of the brainstem is.
It really does. It's a powerful lesson in how one artery's territory can have such wide-ranging consequences.
Okay, so that's acute unilateral.
Yeah.
What if the acute symptoms are bilateral, affecting both sides?
If we're dealing with acute onset bilateral symptoms, especially if it's in children, we start thinking about acute cerebellitis.
Cerebellitis. Inflammation.
Exactly. It's essentially an inflammatory response affecting the cerebellum. This condition is often triggered by various infections, viruses like varicella zoster, which causes chickenpox, Epstein-Barr virus, Coxsackie virus, herpes simplex, or even bacteria like Mycoplasma pneumonia.
Often post-infectious, then.
Often, yes, or sometimes during the infection itself. Patients, especially kids, will typically report nausea and vomiting, headache, maybe some confusion, usually a history of a recent illness, and possibly a persistent fever. On examination, you'll often find altered mental status along with ataxia affecting the limbs, trunk, and gait on both sides.
And how do you confirm that?
The diagnosis is usually confirmed with a brain MRI. It will show abnormally increased signal intensity and swelling, or edema, within the cerebellum, indicating that inflammation.
Okay, that makes sense for the acute picture stroke or inflammation. Now let's shift gears. What if Sarah's symptoms, or someone else's, haven't appeared suddenly? What if they've been developing over a longer period, maybe subacute, over weeks to months, or truly chronic, over many months or even years? The diagnostic path changes significantly then, right?
Completely different ballpark, yes. If the onset is gradual, the very first question we often ask is about family history.
Family history, why is that so crucial here?
Because if there's a history of similar symptoms among close relatives, parents, siblings, we immediately have to consider genetic syndromes. There are many inherited forms of ataxia.
Okay, like what?
Well, one of the most common is spinocerebellar ataxia type 3, SCA3, which you might also hear called Machado-Joseph disease. This is the most common autosomal dominant ataxia.
Autosomal dominant meaning?
Meaning if one parent has the faulty gene, there's a 50% chance their child will inherit it and develop the condition. Patients often report first-degree relatives with similar symptoms, and the onset is typically in adolescence or early adulthood, though it can vary.
And what does SCA3 look like?
Beyond the loss of coordination, the ataxia, they might experience progressive weakness and stiffness, especially in their legs. They can also develop dystonia, which is sustained muscle tightening or twisting, often affecting the neck or limbs. On exam, we'd see the truncal, limb, and gait ataxia, but also sometimes distinct eye findings like eyelid retraction, where the eyelids are pulled back, making the eyes look wide or bulging, impaired upward gaze, and both horizontal and vertical nystagmus. There can also be signs of Parkinsonism mixed in.
Parkinsonism, like Parkinson's disease.
Similar features, yes. Things like rigidity or stiffness, bradykinesia, which is slowness of movement, and sometimes tremors, though usually not the typical resting tremor of Parkinson's disease.
Wow, a complex picture. How's it diagnosed?
It's diagnosed definitively with genetic testing. We look for a specific type of mutation called a CAG trinucleotide repeat expansion on the ataxin 3 gene.
Okay, SCA3. What's another common genetic one?
Another really significant one is Friedreich ataxia. This is actually the most common form of inherited ataxia overall, but it's usually autosomal recessive.
Recessive, meaning you need to inherit the gene from both parents.
Exactly. Symptoms typically begin earlier, often during childhood or adolescence. Patients report the loss of coordination, progressive gait difficulties, but also often numbness and weakness. Slurred speech or difficulty swallowing are common too. And importantly, their medical history might include other seemingly unrelated chronic conditions like cardiomyopathy, a disease of the heart muscle, or diabetes.
Heart problems and diabetes, too. That's interesting.
Yes, it's a multi-system disorder. The exam will show the truncal, limb, and gait ataxia. But critically, there's usually a significant loss of proprioceptive and vibratory sensation.
Proprioception. That's your sense of where your body is in space.
Precisely. So they might have trouble knowing where their feet are without looking. This leads to a positive Romberg test. They lose their balance significantly when standing with feet together and eyes closed because they can't use vision to compensate for the lost position sense. You might also find limb weakness and often characteristic skeletal deformities like scoliosis, a curved spine, pes cavus, very high arches in the feet, and hamatose.
And the diagnosis for Friedreich ataxia.
Again, it's genetic testing, this time looking for expanded GAA trinucleotide repeats on the frataxin gene.
Okay, so family history is key for those genetic causes. But what if there's no family history of similar symptoms for our patient, Sarah?
Yeah.
If we've ruled out a clear genetic link, the puzzle takes another turn. What's next then?
Right. If there's no suggestive family history, the next common thing to consider, especially with chronic progression, is chronic alcohol use.
Ah, alcohol's effects.
Yes. Long-term, heavy alcohol consumption can cause significant damage to the cerebellum, leading to alcoholic cerebellar degeneration. A CT or MRI of the brain would typically show cerebellar atrophy, particularly shrinkage of the vermis, that central part we talked about.
The vermis again?
Exactly. And a key characteristic here is that the truncal and gait ataxia are usually much more prominent than the limb ataxia. Their walking and balance are severely affected, sometimes more so than their arm coordination, precisely because the vermis is the primary target of the damage in this condition.
Makes sense. Okay, so we ask about family history, then alcohol use. If neither of those applies, where do we look?
If there's no family history and no chronic alcohol use, then we dive deeper into the specific combination of history and physical exam findings, which might point towards several other important conditions.
Okay, what are some of those?
One possibility is a Chiari type 1 malformation. This isn't degeneration, it's a structural issue.
Structural how?
It's where the bottom part of the cerebellum, the cerebellar tonsils, sits lower than normal, actually pushing down through the foramen magnum. That's the large opening at the base of the skull where the brainstem connects to the spinal cord.
So part of the cerebellum is kind of herniating down.
Essentially, yes. Patients often report posterior headaches or neck pain that get worse with things that increase pressure in the head, like Valsalva maneuvers, coughing, sneezing, straining.
Okay, prior headaches.
They might also notice progressive weakness and sensory loss, often particularly in the arms, and they can experience slurred speech, hoarseness, or trouble swallowing if the brainstem is compressed. On exam, truncal ataxia is often more prominent than limb ataxia. We might see a specific type of nystagmus called downward beating nystagmus.
Eyes beating downwards.
Yes. Also potential cranial nerve problems, signs of spasticity or muscle stiffness and weakness, and sometimes a very distinctive cape-like pattern of sensory loss, losing pain and temperature sensation over the shoulders, chest, and arms.
Wow, a cape pattern. How's Chiari confirmed?
An MRI of the brain and cervical spine is needed. It clearly shows that downward displacement of the cerebellar tonsils below the foramen magnum, and it's quite frequently associated with something called a syrinx.
A syrinx.
Yeah, that's a fluid-filled cyst that can form within the spinal cord itself, often in the cervical or upper thoracic region, likely due to the altered cerebrospinal fluid flow caused by the Chiari malformation. And that syrinx can cause its own set of neurological problems, like the weakness and sensory loss.
Okay, Chiari malformation. What else is on the list for chronic, non-genetic, non-alcoholic causes?
Another important one to consider is multiple system atrophy, or MSA, specifically the cerebellar type, sometimes called MSAC.
MSA, that sounds serious.
It is. It's a rare, progressive neurodegenerative disorder that, as the name suggests, affects multiple systems in the body. Patients often report a real mix of symptoms because it involves autonomic dysfunction.
Autonomic, meaning the involuntary function.
Exactly. Things like blood pressure control, bladder function, bowel function. So they might experience severe dizziness upon standing, what we call orthostatic hypotension, or urinary or stool retention or incontinence. They also develop Parkinsonism, the slowing of movements, rigidity, maybe tremors and cerebellar signs like ataxia.
So it's like Parkinson's plus ataxia plus autonomic failure?
That's a common way to think about it, yes. A partner might also report hearing a high-pitched sound when the patient breathes during sleep. That's called stridor, and it's due to vocal cord dysfunction, which can be dangerous.
Stridor. Okay.
The physical exam would look for those vital sign changes with orthostatic hypotension, the various types of ataxia, the scanning dysarthria or hoarseness, the signs of Parkinsonism, and maybe audible stridor.
And imaging.
A brain MRI is very helpful. It often shows atrophy or shrinkage of the cerebellum in the pons, part of the brainstem. And sometimes there's a distinctive sign called the hot cross bun sign in the pons.
Hot cross bun sign. Seriously.
Yes, it's a cruciform or cross-shaped pattern of hyperintensity seen on certain MRI sequences. It's not always present, but when it is, it's quite suggestive of MSA, reflecting degeneration of specific nerve fiber tracts in the pons.
Okay, MSAC. One more.
One more important category, especially in older adults, is paraneoplastic cerebellar degeneration.
Paraneoplastic, meaning related to cancer.
Exactly. This is a rare but fascinating disorder where the body's immune response, mounted against a cancer somewhere else in the body, mistakenly attacks cells in the cerebellum. Sometimes the neurological symptoms appear before the cancer is even diagnosed.
The immune system attacking the cerebellum because of a tumor elsewhere.
Precisely. The symptoms can be somewhat nonspecific initially, maybe dizziness, nausea, vomiting, progressing to slurred speech, trouble swallowing, and significant ataxia. The crucial clue here is often the patient's history, either a known history of cancer, specifically types like lung, breast, gynecologic cancers like ovarian or Hodgkin lymphoma, or the subsequent discovery of such a cancer shortly after the neurological symptoms begin.
And how do you confirm this is paraneoplastic?
The exam shows the ataxia, but the diagnosis relies on finding specific antibodies in the patient's serum or cerebrospinal fluid. We run specialized tests called paraneoplastic panels, looking for antibodies like anti-Yo, anti-Hu, or anti-TR, among others. These are antibodies known to target cerebellar cells in the context of certain cancers.
Finding those antibodies really points the finger at an underlying cancer driving the cerebellar problems.
It does. And it obviously has huge implications for treatment, needing to address both the neurological symptoms and the underlying malignancy.
Wow, what an incredible journey we've taken through the complexities of cerebellar lesions. From Sarah's potential initial symptoms to the detailed physical exam findings, the different ataxias, the eye signs, the speech changes, and then branching out based on that crucial timeline. Acute versus chronic. It truly highlights how all these symptoms are vital clues in diagnosing these conditions. It really is like a finely tuned detective story playing out right inside the brain.
It absolutely is, and it really reinforces the importance of a systematic approach in diagnosis. You have to put all the pieces together. Understanding the timeline, the specific exam findings, associated features like family history or other medical conditions, that allows for, hopefully, a precise identification. And, if we connect this to the bigger picture, it just underscores the brain's incredible complexity, but also its resilience, constantly working to maintain balance and coordination, even when parts of it are challenged. Each case really is a testament to that.
Yeah, and it really makes you appreciate the subtle marvel of everyday coordination that, frankly, most of us just take completely for granted, doesn't it? This deep dive shows just how many intricate pieces have to be in perfect harmony for us to simply walk across a room or talk to a friend or just reach out and grab an object. It's this silent, constant masterpiece happening inside our heads.
Couldn't have said it better myself.
So here's a final thought for you, our listener. Thinking about the cerebellum's role in this silent, seamless coordination of our daily lives, how might a deeper appreciation of this maestro of movement change how you observe the simple act of walking or reaching for an object next time? And what might that awareness tell us about all the hidden, continuous processes happening constantly within our own brains that we never even consciously acknowledge? Something to ponder. Thank you so much for joining us for this deep dive. Until next time.